And today we're going to be talking about the details of formulation and dosing of buprenorphine. The objectives today, and I guess I should just say, if for some reason I cut out, I'll try to keep an eye on the chat and on my phone in case I see Julie like frantically texting me that I'm no longer, no one can hear me anymore, because I could turn off my video too. I think that might help. So the objectives today, maybe I'll just do that, are to describe the differences between the formulations of buprenorphine, to discuss the difference between protocols of home-based initiation and the classic-based initiation of buprenorphine in the clinic, to learn about dosing and duration of maintenance treatment, so staying on buprenorphine, along with management of potential diversion, and to create a plan for managing the process of medical withdrawal. So helping basically if someone is tapering off or needing to taper off of buprenorphine in those cases. So let's talk first about the formulations. There are many and more being studied and on the horizon. But what I'll draw your attention to is that we have the combined product, which is usually what we'll be prescribing, and that's combined with naloxone. And then there's the mono product, which is buprenorphine alone, which for the most part in its sublingual form, we'll just be prescribing in pregnancy in case there's a known true allergy, which is rare but can occur to the naloxone component. And then the other, we don't use the implant, but the other mono product would be Sublocade that we'll talk more about, the monthly injection. But you can see that the available doses in the combined product here, mostly we'll be talking about this in the film form. Most of the time will be the 8 milligram, 2 milligram, but we do have these other options, and the 2 milligram one here at the top can be particularly useful in microdose starts that we'll see. There are some tablet forms still available, and the Subsolve is that form. And I'll just draw your attention to the equivalent dose of Subsolve, which usually is just based on the insurance that we may use that. And the equivalent to the 8 milligram is actually 5.7 milligram. And then we have the buccal form. So these are all forms that will be dissolved under the tongue or inside the cheek. Sorry, I'm going to try to clear my, I'm going to turn off my, as much as I can, that's making noise on my screen. Okay. So the buprenorphine naloxone should be used for treatment of opioid use disorder. So this is not for treatment of pain, although it does certainly have that benefit, but it's for treatment of opioid use disorder. And the naloxone component, why is that there? It's there basically to decrease the chance of diversion, because while it is absorbed directly if injected, it is not well absorbed if it's taken as prescribed, so sublingually, or if it's ingested orally. If it's injected, however, it does cause, in someone who's opioid tolerant, so taking opioids, it does cause precipitated withdrawal, and so that is why it it helps against potential diversion or misuse of the medication. So you can see here again, also listed as we were talking about on the previous slide, the different formulations for the sublingual, and then when we would use the mono product. So do we take the film or the tablet? This is largely driven by pharmacy availability and insurance coverage. Most of the time we're using the film, it dissolves more quickly. So usually in around 5 minutes as opposed to 10 with the tablet. And then possibly there's a decreased risk of diversion because of the individual it's harder to access as it's individually wrapped in these foil packets. That can also make it harder for someone who, like a child who's not supposed to get into it, to get access to it. Although of course we still want to make sure with our patients at each visit they're keeping this locked and high up and away from others who could get into it. So looking at the treatment options, we have the that kind of breaks down for you here what to consider when someone's deciding between the self-administered or sublingual form and the injectable form. So not the implant, but the injection. So really the current standard of care is the sublingual form. There's many doses, as we saw in Formulations. It's quite accessible. And with everyone prescribing more and more of this, then it will become more accessible. So we are hoping to increase access, because there's still in some areas quite limited access. The diversion risk is real, though, and most of the time when this medication, the sublingual form, is being diverted, it's usually to aid someone in their withdrawal, but we still want people to be taking it from a prescription and try to decrease the risk of diversion. And there's moderate costs associated with it. Now, when compared with the injection form, we have less clinical experience with this. However, there's more, and I think today with the Sublocade, the brand name, and there's more forms being studied. There's a closed distribution system. So this one has to be delivered to a clinic and get administered in clinic. So it's basically essentially takes out the potential for diversion. Enhanced compliance. So I think as far as adhering to this medication, as long as the patient is coming in every 4 weeks, they're more likely to have a reliable dose in their system. They're not going to be coming on and off of it, as could potentially be the case with the sublingual form. And it certainly does cost a lot more, so does require generally a prior authorization to take this medication, but most of the time we can get it approved. So we're going to start talking about at-home initiation of buprenorphine. Is it feasible? Is it safe? And is it effective? And the resounding answer is yes to all three. And this was really well established in this study by Josh Lee in a 7-year outcome study out of New York that was an N of 485. It was a population that was quite reflective of our population here. I think largely patients largely on in an urban underserved setting, a large Medicaid insurance representation. And they showed that the 1 week dropout was 17%, the induction related adverse events at 12%, 0 serious adverse events, and precipitated withdrawal and prolonged withdrawal were relatively low. And importantly, the median treatment retention was 57 weeks. And what this reflects is really at least the same safety and retention treatment standards as we were seeing with initiations in clinic, which we found over time have more barriers and more difficult than home initiation of the medication. So for the most part, this is the standard of care. So what is the process? We might consider excluding patients who would be candidates for home initiation who have a low tolerance for withdrawal and may feel very uncomfortable with it. Patients who are transitioning from methadone, those transitions can be more challenging and sometimes may benefit from the support that a clinic can offer. Patients who have cognitive impairments, and especially if there's not support at home, then this would not be a good candidate to start and be able to follow the instructions for a home initiation. Patients who have untreated psychiatric conditions and certainly suicidality, if there's an emergent need for treatment, we would not be sending them home for initiation. And certainly patients who have significant fear of withdrawal, either because of an experience they had before, or maybe they have not experienced this transition before and onto buprenorphine, and they're worried about what it might be like. So what do we instruct people to do? So first, we're going to be talking about kind of the more traditional approach, and this is really what goes back to the waiver course that many of you may be familiar with, and also really more I would say, fentanyl, which is where we'll talk more about what initiations are like for buprenorphine in the time of fentanyl as well. But The standard approach is to wait until you're feeling very lousy, so in significant withdrawal. So we would instruct people to wait at least 12 hours since the last use of short-acting opioids and at least 24 hours since the last use of long-acting. You can consider providing a patient with their SOWS, so the scale to evaluate their opioid withdrawal, and that will be coming up here in the next slide, I believe. And circle or point out for them that the target score should be at least 17 to help decrease the risk that they'll be precipitating withdrawal when they start. Then when they feel like they are in enough withdrawal, have waited pretty much as long as they think they can and should, then they would start with a 4 milligram dose. And usually we'll have people just cut that strip in half to start, the 8 milligram strip in half to start with a 4 milligram dose. And then they can repeat that about every 1 to 2 hours if the withdrawal continue, which most likely, they will, for a total dose of 12 to 16 milligrams on day 1. And this oftentimes, will go towards the higher end of the dose on day 1, with the exception of if someone isn't going through this whole process and they have very low tolerance and they're really starting, they've already gone through withdrawal and are having cravings, and that's why we're treating their opioid use disorder. We want to be cautious as far as the dose and their tolerance. And then certainly going over with them that it's okay and recommended to call the clinic in the case of precipitated withdrawal to get support for that. So this is the example of the SOWS, and you can just kind of scan this list here. I'm not going to read through it all, but this is the patient basically scoring themselves from not at all to extremely on multiple symptoms with opioid withdrawal. So then on day 2, you're going to instruct them to take the total of what they took on day 1 in the morning. So if they had taken, and this can be something that's really important actually to still go over with people, even if they've tried it before, because I often find that people will sometimes misunderstand and continue to take sort of split doses throughout the day until their next follow-up. But it's important that they try to consolidate that that stepwise approach that they did on day 1. Let's say they got up to 16 milligrams by taking 4 milligrams 4 times, but then when they wake up the next morning, they want to take that total in the morning and check in with you in clinic. And then later in the day, if they're still having some withdrawal, then they can take an additional 4 milligram dose until a maximum of 16 or even up to 24 milligrams is often the case on day 2. Day 3, if needed, we'll be in touch with the patient and still in that stepwise manner, maybe adjusting the dose. Usually with the first prescription, most community settings, it would be fine to provide enough for 1 week. This is in general good to kind of assess your clinical practice and talk with colleagues about what seems like a good setup for your clinic, but that's usually a good amount. And I tell people, that we'll provide enough for 1 week of what we think might be the most that they would need each day, but they may not reach that amount, in which case when they come back, they may have a little extra, and we'll just ask them to keep track of that. And again, we want to try to get to that target dose quickly in the first couple of days so that we get those receptors, the mu receptors, as fully occupied as possible, so that you'll be less likely to feel withdrawal and craving, less likely to experience a lapse to opioid use. And then really at that point, after we get to that dose quickly, we'll allow 5 to 7 days before adjusting the dose further. Let's say if they didn't in the first few days need more than say 16 milligrams, then we might be able to wait and see if they'll be fine at that dose, or if perhaps they'll need a higher dose. So again, how long do we wait? Usually 12 hours for short-acting opioids such as heroin, most long-acting opioids 24 hours, and then methadone is longer, at least 36 to 48 hours. And we always want to discuss the possibility that withdrawal may be precipitated, not to discourage anyone for sure, but to make sure that they're aware of how it can be managed and how we can help them push through it and still stabilize on their buprenorphine. So what about transitioning from methadone? In general, what's been recommended is being on 40 milligrams or less for at least 1 week, and then being off the methadone entirely for at least 48 hours. We would certainly want to provide medication that helps with the symptoms of withdrawal, such as Clonidine for sort of that internal like anxiety feeling, ibuprofen, loperamide, trazodone, hydroxyzine for anxiety or insomnia. And then start at that 4 milligram dose once in withdrawal, as was previously described. There's some times when even a smaller dose, so kind of we'll talk about microdosing, can be useful for methadone transitions. Again, if we do precipitate withdrawal, it's usually better managed if we've discussed it ahead of time. And the important thing here is what's in red, to provide more buprenorphine. So not to stop the initiation and wait for another time, but to continue with it and explain to the patient that they will push through it, but it is going to take longer for that kind of to wash off of, and the buprenorphine to take hold of those receptors. Again, the medications that we discussed for symptomatic management. And if someone has this happen at home, certainly having the patient come into clinic, if this happens, having that be a possibility for them is good. So we'll turn to talking a little bit about the microdose inductions. And this is when small buprenorphine doses are administered stepwise to reduce the risk of precipitated withdrawal and pain associated with that. And it can be especially useful for patients who have chronic pain or for patients who are not able to stop using their opioids. Certainly this can help if someone isn't going to be, say, stopping and waiting the time until they feel like they're in enough withdrawal to start. And we'll talk about how they can start while they're still on the opioid pain medication. Opioids, pardon me. This process takes advantage of buprenorphine having a very high affinity at the mu opioid receptor and being able to bind stronger than the other opioids. Because of that, the pre-existing opioid can be tapered after the buprenorphine is started. So this is kind of a classic picture of how this works. And you can see here that the dose, the total daily dose in this microdose induction is very small. And so 0.25 milligrams is going to be 1/8 of a 2 milligram film. So very small. Did I say that right? Is it? Yes, 1/8. And while they're still on the opioid, they can take just that small amount on day 1, day 2, going up to that twice a day. And you can see the dose building here up until day 7. You've transitioned at this point to the 8 milligram strip and taking 4 milligrams twice a day. And then by day 7, this is when the dose at that mu receptor should be sufficient of the buprenorphine, and they would be able to stop the opioid that they had been taking. So this overlap has allowed for them to ease onto the buprenorphine. So just looking at the time here, and did we, Julie, you said we still didn't have a case. Is it okay for me to go over a little bit? Because we're just at maintenance now, and I just wasn't sure if anyone had, I hadn't seen in the chat if anyone had said they had.
No, I did not see anybody had chatted in that they wanted to take the time. So just again, folks, if you want to have some time between 12:30 and 1 to present a question or to identify case, just chat in so we'll know. And if not, I'll let Dr. Jacobson
and Snehal here. And the other thing is that, if no one has a case, I have a hopefully a fairly quick one that I can bring up at the end.
Great, and we hear you, who just said you joined. Just chat in the chat who you are and where you're from. Thank you.
Great, thank you. Yes, I'll go ahead with this. I'll try to make it fairly brief so that we do have time, certainly if someone else has a question or case, and then for Dr. Botts. So as far as maintenance dosing is concerned, the FDA maximum approved dose is 32 milligrams. Most insurances still cover up to 24 milligrams, but we are in the age of fentanyl, oftentimes trying to get people up to higher to the 32 milligram, and we'll sometimes need to push for that with the insurance. Can be helpful to keep track of the doses in your clinic, just to kind of get a sense overall, make sure that sometimes we'll find that people are staying rather low, and that can be kind of under treating patients. And so it's helpful, I think, to kind of keep track of the doses that are being prescribed. What about how long of a prescription to give? And this is really tied to how the patient's doing. So how are they doing keeping visits, taking the medication that's prescribed? How are they doing with their goals for treatment? As I said before, it's generally fine to start with a weekly prescription. And this is just kind of giving an example of what it might look like. You definitely don't have to buy necessarily replicate this, but so for instance, maybe a weekly prescription and check in weekly for about 4 cycles. And then if they're relatively well and stable, having started on the medication and doing well with their dose, then considering a 2-week prescription for a few cycles, and then monthly and a refill. And we can, in some cases, when patients are very stable, can see them every 3 months. How do we manage diversion? So these are a few tools that can be useful. Certainly at each visit, it's recommended to have your toxicology screens, and including checks for buprenorphine metabolites to make sure that the medication is being taken as prescribed. The metabolite check doesn't have to be done every time, but certainly with some of the urines, if your lab doesn't immediately include it, you may need to request that. And the urine tox screen is really meant as a tool to help with treatment and open a conversation with people. It's never meant to be like a reason for decreasing someone's dose or discharging them. We always check the PDMP. 48-hour callbacks, that's really clinic dependent. Our clinic does that more because of our being an OTP treatment program, but really, if indicated, you may consider doing a callback if you have concern about patients actually having their medication and taking it. And then we always want people to keep safe storage of their medication. So now just to turn to high potency synthetic opioids, so namely fentanyl. What do we see as far as buprenorphine treatment with fentanyl? In general, we see that people are doing pretty well with getting started on it. However, we do see increased reports of precipitated withdrawal. And importantly, this question comes up a fair amount in I think the medical community, is how effective is it? And importantly, buprenorphine naloxone treatment retention, once patients start on it and staying off of opioid rates, these appear equivalent based on this study by Wakeman in heroin, someone who's on heroin versus fentanyl. Why do we see more precipitated withdrawal? There's a few theories. One is the decreased renal clearance with fentanyl. Also, lipophilic nature may make it more long acting over time. Interestingly, it's not seen when a fentanyl patch is replaced with a buprenorphine patch. So that's something that we may see like in a hospital setting with that transition, and we don't tend to see precipitated withdrawal. So we do have a few ways to try to start someone on fentanyl, to start them on buprenorphine from fentanyl, even though these starts are more challenging. One way to consider is with the microdose approach. So basically the start low, go slow idea, waiting longer to get into withdrawal, aiming for a higher COWS score. So as opposed to the SOWS, this is the clinical opioid withdrawal scale. So having it be at least 13 to 15. I don't know, self-report being unreliable, I think is, I'm sorry, was someone trying to say something? Well, maybe I heard myself echo. Okay, sorry. Okay, I think I saw Julie shake her head that everything's okay. Okay, thank you. So I think that some people certainly, have had the experience already and may be able to tell when their symptoms are just right for starting it. But sometimes it's very hard to say. And so that's why the scale, providing a scale to go home with can be helpful, or doing the scale in clinic. Again, we want to provide those medications, comfort meds. And then the microdose approach would be to start at a small amount, so about every 1 to 2 milligrams every 1 to 2 hours, and aiming to get to 16 milligrams by day 2. But most likely we will need to build up on the dose, especially with fentanyl, to decrease cravings and relapse risk to 24 milligrams at least. And then just to keep in mind that some may need methadone. So either because of the potency of fentanyl, they may need that full agonist effect of methadone. They may have a difficult time with the transition, and just remembering that may need to be an option for someone, although in some communities that can certainly be more challenging. This is a small case series just looking at 4 individuals who were started with the microdose approach, and the 2 individuals who completed the revised microdose approach did not precipitate withdrawal. So some information here is supporting its use. And then the macrodose approach, which I think, I can't tell if Dr. G's on right now, Dr. Domsky, but he had certainly spoken to the benefit of this as well in the time of fentanyl with the patients that he's treated. But I think we're all seeing that there may be quite a bit of benefit to the macrodose approach, which is essentially, as you can see here in this study from Lee from 2020. Here's patients, 5 patients listed here, who at day 1, they were basically, once they reached the cows of 10 to 12, they had their first dose of sublingual buprenorphine, ranging here from 10 to 24 milligrams, and then an additional dose on day 2, or in some cases, they immediately transitioned to the Sublocade, which is the buprenorphine injection at the 300 milligram dose, and that by day 4, their cows were essentially, their withdrawal was essentially next to nothing, or a scale of 0. And they certainly had, as far as the follow-up as well, they showed that they were doing pretty well in terms of not using and staying in treatment. And this macrodose approach is actually looking at phase 2 of this, looked at actually starting that high dose even on day 1. So they gave 1 test dose on day 1 and then immediately transitioned to that long-acting injection on the first day of treatment. So I think there's going to be a lot more information coming as far as starting buprenorphine in the time of fentanyl. And then just to touch upon withdrawal. So really, we're not encouraging patients go through this, and we want them to stay on their medication for as long as they're benefiting from it, really because we see in these studies high rates of relapse with withdrawal. And that patients can be on the medication long-term, and that retention and treatment when they stay on the medication, which is key to survival, is seen when patients stay on their buprenorphine. So again, we want patients will come in sometimes from their first visit and ask how soon they can get off of this. And while that may be a goal that, we certainly want to walk with our patients and what their goals may be, I never want them to feel that there's like a time stressor for that to get off of the medication. If it's something that they have as a clear goal for themselves, we really want to make sure that they are feeling stable from other points in their life, and for instance, employment, family relationships, improvements in their health, etc. If they do choose to withdraw from the buprenorphine, there's really no evidence of the length of a taper that's preferable. But generally we will, if patients can, we will try for a longer, more gentle taper. We just know that there's a high relapse rate regardless. And that's certainly, we want to inform patients that the risk of overdose is greater after withdrawal because of the loss of tolerance. So if they were then to use, they have much more increased risk of overdose and fatality. So again, we want it to be when someone's functional goals are met, at their own pace, try to keep them engaged in treatment. You can consider naltrexone injection upon completing a withdrawal, perhaps to decrease their risk of a relapse. And I will stop there. And see if there's any questions or comments.